Hello, I'm Julia Margulies, Hospital Services Specialist with the Washington Regional Transplant Community. Today I'll be presenting a brief overview of organ, eye, and tissue donation. WRTC is an organ procurement organization, or OPO, that is federally designated and a not-for-profit organization. We are responsible for recovery and allocation of all organs and tissues for transplantation and research. Our service area is also federally designated. We cover what is basically the Washington, D.C. metropolitan area of surrounding Maryland counties, Northern Virginia counties, and the district. There are 58 different OPOs in the United States. So why donation? At this point, the national wait list is over 123,000 patients waiting for a life-saving organ. Here at our local level, there are over 2,000 patients waiting for a life-saving transplant. This list keeps growing. And sadly, approximately 21 people every day die from that wait list because they did not get a life-saving organ. A new patient is added to the wait list every 13 minutes. Organs for transplantation include heart, lungs, pancreas, liver, kidneys, and small bowel. We have one of the few small bowel transplant centers in our area, and that's Georgetown. One organ donor can save 9 lives. Lungs can be split between 2 recipients. Kidneys, of course, go to 2 recipients, and the liver can be split and go to 2 different recipients. Tissues that are recovered for transplantation include skin, which is still the best temporary bandage for burn patients, bone, which is used extensively by orthopedic surgeries and in some cases used when a cancer must be removed from a patient. The patient can then receive a bone graft that would help them maintain the use of that limb. Tendons, ligaments used for sports injury repair, ACL repair of course, but also can be fashioned into what's called a bladder sling. Saphenous veins can be recovered and used for dialysis port repair, bypass surgery, and graft veins for diabetics. Hearts, if they cannot be transplanted, can be recovered for valves. Pericardium can be recovered and used in neurosurgeries. And of course corneas for restoring sight. One tissue recipient can impact 50 to 100 lives. The pathways to organ donation include living donation. I'm sure you've heard of someone donating a kidney to someone in their family, in their community, or even altruistically to the wait list. There are also those that have donated a portion of their liver. Generally that is done within families since there is a higher risk to the donor for a partial liver donation. The pathways for organ donation here in the hospital include a patient that would be on a ventilator, is vent dependent, and has been declared dead by brain death criteria. So brain death, I'm sure you're very familiar with, but I'll just sum it up as being the irreversible loss of all clinical function of the brain, including all the brainstem reflexes. So that is a clinical bedside exam where they are checking for pupillary response, corneal, cough, gag, and response to pain, in addition to doing a full apnea test. If the patient qualifies as being dead by brain death criteria, they are able to be an organ donor, and all organs are considered for transplantation. The second pathway is donation after circulatory death, or DCD. This would be a patient with a severe neurological injury that is vent dependent, and a family has decided that they are going to withdraw care due to the injury being non-survivable. In this situation, the patient could be considered for organ donation if they are expected to pass within 60 to 90 minutes of the vent being disconnected. In that situation, we are able to look at lungs in certain situations, possibly liver if the patient is expected to expire very quickly within 15 to 20 minutes, but we are able to use the kidneys in that DCD situation. That is still a very, very meaningful donation, as over 100,000 of those waiting on that death list, or on that recipient list, are waiting for a kidney. For tissue donation, primarily the tissue donors come from patients who have died in the hospital of cardiac death. These are non-vented patients who have died in the hospital. However, a brain dead or DCD donor can also be a tissue donor. So there are policies and laws that regulate how OPOs and hospitals work together. There are state and federal laws. Each state has their own donor registry. Hopefully you are all registered as organ donors on your driver's license. That's one way to register. But you can also register at our website, beadonor.org. When you go to our website, you can click on Register Now and then choose the state where you reside, and a link will take you directly to that website where you can register yourself. Each state has a Uniform Anatomical Gift Act, which says that designating yourself as an organ donor is considered first-person consent. It's treated as an advance directive where you have said that you would like to be a donor at the time of your passing. There are also hospital policies that regulate donation. All of our hospitals have their own organ, eye, and tissue donation policies, which cover tissue donation and brain dead and DCD organ donation. For Joint Commission standards, there are two policies that are important for you. One is called the Required Request Standard. That says that every family should be given the opportunity for donation when it is available and when it is appropriate, and that request should come from the local OPO, someone who's been trained to work with families. And then also the required referral, which says that each hospital will refer all hospital deaths within 60 minutes of asystole, that would be for tissue and cornea donation, and will refer all vented patients meeting particular clinical triggers. The donation process begins with a phone call from you here at the hospital. The clinical triggers that I mentioned on the previous slide pertain to a patient who is vent dependent and meets one of the following clinical triggers: a Glasgow coma score of 5 or less without continuous sedation, if brain death testing is being considered, prior to a discussion of withdrawal of life-sustaining therapies. So if a meeting has been scheduled with the family where the family will be receiving a grave prognosis, we would like to know about that meeting in advance in case that family does decide to withdraw the vent. If a patient is made DNR or comfort measures, we need to know that within 1 or 2 hours of those orders going into effect. As soon as pressors and fluids are stopped, organ function can be impacted very quickly. And lastly, if a family initiates a conversation about donation, we ask that you let them know that you can get someone here in person or on the phone to talk to them about their questions. When you make that referral call to WRTC, you'll be calling our call center, and they'll be asking you information about the patient, their name, date of birth, medical record number, current admission course, and past medical history. You are able to share all of that information with us because we are HIPAA exempt. It also will be very important to give us the next of kin information and a current, up-to-date phone number. For tissue donation, so this would be after a cardiac death here in the hospital, we do need to contact the family within several hours of the death. We will need to have a good phone number to get in touch with them and offer them the opportunity for donation. Next comes the evaluation for medical suitability. For a tissue donor, we will be evaluating to see if there are any of those risk factors that would disallow them from being a tissue donor, in which case we would not contact that family. For an organ donor, we will be coming on site and doing a full chart review to see if there is potential for organ donation. When we come on site for a potential organ donor, we are not coming to talk to the family immediately. We're actually coming to huddle. We would want to include in that huddle nurse, the attending, neurology, social work, chaplaincy, anyone who's been involved in that patient care and working with supporting that family. We will be talking with them about the patient's suitability, about their plan of care, and about the family to find out where that family is as far as accepting a great prognosis and how they're handling that information. We will not talk to a family until the family has been told their loved one is either brain dead and they've been given a date and time of death, or the family has made a decision to withdraw the vent, and we are able to offer them the opportunity for donation after circulatory death. We will always talk to a family in coordination with you, the care team here at the hospital. To summarize, the two things you need to know about working with WRTC on organ, eye, and tissue donation are: 1, call on every death, no exception, and within 60 minutes of asystole. You do not need to wait for the doctor to come and pronounce the patient and write the death note. We need to know the cardiac time of death. Secondly, please do not mention donation to any family. We will only approach families with the opportunity for donation if the patient is suitable. We have people who are specifically trained to work with and counsel families on this opportunity for donation, and they are the ones that are actually designated to offer that opportunity to those families. If you would like to learn more about organ, eye, and tissue donation, please attend one of our donation resource specialist trainings that we offer once or twice a month at our offices in Annandale, Virginia. You can register online at www.beadonor.org/DRS. If you have any questions or comments, please email hospitalservices@wrtc.org and using the subject line GNO questions. Thank you so much for your time.